good morning, good afternoon, and good evening, everyone. Welcome to another week of Global Cafe, as Luana mentioned. Today is our last Global Cafe for 2024, so we're really excited to have you all here today. My name is Mitali Mistry, Senior Policy and Project Coordinator here at the IFA, and today I'm very excited to be introducing you all to Dr. Whitney Scott on the topic of promoting equitable access to holistic and person-centered pain care. As the third and final session of our Global Cafe Pain Management series that is in partnership with Haleon. Dr. Whitney Scott is a senior lecturer in clinical health psychology in the health psychology section of the Institute of Psychiatry, Psychology, and Neuroscience at King's College London. She is also a registered clinical psychologist at the and the research lead at the Input Pain Management Unit at Guy's and St. Thomas's NHS Foundation Trust in London, UK. She has published over 80 peer-reviewed journal articles on psychosocial factors related to pain and psychosocial treatments for managing persistent pain. She is particularly interested in the social context of pain and equity of access to person-centered pain care. Her work has been funded by the International Association for the Study of Pain and National Institute for Health Research. She is currently a co-investigator on the large multidisciplinary Painstorm Consortium, which is funded by the UK's Medical Research Council and Versus Arthritis Advanced Pain Discovery Platform. Painstorm is working to understand the complexity of biopsychosocial factors that drive neuropathic pain. Thank you so much for joining us today, Dr. Scott.
Thanks for that introduction, Mitali, and thanks everyone for joining. I'm aware that for some of you it's very, very early in the morning, so especially thank you to you for showing up.
Absolutely. So with your wealth of experience in the field of pain management and clinical psychology, I was wondering if you could start our conversation off by telling us how you got into the work that you do today and what has motivated you along the way.
Yeah, it's a great question. So I guess first and foremost, it started as a personal journey. So I grew up with a mom living with persistent pain, and I very much observed the impact that that had on her as well as our family. And then fast forward a few years when I was doing my undergraduate degree at the University of British Columbia. I'm Canadian, although I'm currently living in the UK. So at UBC, I did a course in health psychology where I began learning about what pain is, including the role of psychosocial factors. And a lot of that really clicked with me based on kind of my experiences in my family. And I was really fortunate that there happened to be really a world-leading expert on pain psychology, Professor Ken Craig, who agreed to supervise my undergraduate research project. And that kind of set a path for me of being really passionate about pain research and pain care. And then along the way through my training and my kind of subsequent career, really what's kept me motivating is seeing the real benefits that psychology can have in supporting people living with persistent pain. So that's been a real motivating factor for me, and the impact that the role of psychology can have in this area.
Fantastic. Thank you for sharing that with us. I'd love to know that there's another Canadian across the pond. So your focus on pain management is through a biopsychosocial lens. Can you broadly explain how we can look at pain management through this lens and maybe explain a little bit about what biopsychosocial might mean?
Yeah, definitely. So very much kind of as indicated by the name, we know that pain is a complex experience. It is comprised of biological aspects, so things like a person's genetics, how their nervous system and immune system functions. We also know that there's a role of psychological factors, so the thoughts and feelings a person has about pain, what they do in response to pain, as well as social factors such as the culture that a person lives in, their social support network, their working context. So all of these things work together to shape the experience of pain a person has, as well as how much that pain impacts on a person, or how disabled or distressed they are by that pain. And I think it's really important. So certainly you've had talks by other researchers and clinicians in the pain field, possibly from a more biomedical angle. And often that's the way these talks go. You have someone kind of on the bio aspect, someone on the psycho or social aspect. But it's really important to emphasize that these things all work together. And as a psychologist, I'm also really conscious of the perception that even me being here talking about pain, there is perhaps a view that that means that I think that pain isn't kind of real or physical. Certainly, the role of psychological factors like thoughts and feelings does not undermine the role of biological influences. And as I said, we need to be thinking about all of these things together. And generally speaking, the role of psychology might not be so much in the kind of onset or start of pain. It might more actually be related to how a person adjusts to the experience of living with persistent pain, or how disabled a person might be with that pain.
Yeah, thank you for clarifying that and also kind of adding that aspect. And I think it's something that we might have in the back of our
Mhm.
heads. So it's good to think about it in that way in terms of
Mhm.
psychology and pain and the relationship between each other. So, what role do psychosocial factors plan in managing persistent pain?
Yeah, so we can broadly think about these if we start kind of with the psychological factors. So those are things like a person's thoughts and feelings about pain. So it's really normal, particularly when pain lasts a long time, to be quite worried about that pain, to be frightened by it, to be thinking about what does this actually mean, what's happening in my body. There's also really natural thoughts and feelings around frustration, anger, embarrassment. And all of these things are really normal human experiences when a person has pain. And sometimes, when those experiences are the guide for a person's actions, they can become unhelpful, particularly when a person's pain lasts a really long time. So, if someone is really, really understandably fearful, but they keep acting in response to that fear, they might start avoiding situations more and more. And that might mean that their life becomes smaller and smaller. Again, that's a really incredibly normal human response, but it may no longer be helpful in the context of persistent pain. So that's kind of one aspect that psychologists might work on, is helping people to first even notice that there are thoughts and feelings that show up around pain. So pain, of course, is a physical experience in the body. It's also comprised of these thoughts and feelings that come alongside. And then in looking at some of the social factors, looking at how a person is engaging with their social network. Again, it's really natural when pain is a part of the picture that people might withdraw from social life because it's painful to do that. The things or activities they used to do might no longer feel possible. And unfortunately, there are situations where the social network isn't always as understanding or validating or empathic and compassionate as we would hope them to be. So that can really add to the suffering that comes with pain. So we can support people to navigate their social network, to find, helpful ways of communicating about pain, and also finding ways of connecting with people that they care about in the ways that are important to them, that really appreciate the challenges that come with pain.
Yeah, absolutely. And just kind of along the lines of, the social factors related to pain, we do have a question here in the chat, which I think
Yeah,
maybe we can kind of pop in right now. It's
great.
from Shmuel, and they ask, according to you, for effectively promoting equitable access to lower those coming from more middle income kind of situations, how can we kind of do that so that they have that holistic and like person-centered pain care?
Yeah, it's a really great question. And I think in part it also depends on where you're based in the world.
Yeah.
So I'm aware that this is a fairly international group. I'm based in the UK, where we're quite fortunate that we have the National Health Service, which is effectively free healthcare at the point of access. There are still many, many challenges within that. So I'm not certainly saying that this is, the optimal solution. But certainly, I think we need to be thinking creatively about whether it's someone with from a certain socioeconomic background or other potentially marginalized groups. Our kind of model for many, many years, for decades, in fact, has been really providing this kind of holistic, multidisciplinary pain care at very specialized pain services. They often tend to be concentrated in cities, in kind of affiliation with academic centers, and certainly not everyone can access those. The capacities to navigate a healthcare system to get to that tertiary level of care or specialty care requires a lot of, perseverance. It requires a lot of cognitive, capacity and persistence. So I think if we think about broadening out beyond specialty pain services in a range of different ways, so this could include, better community-based pain care, whether that's through primary care, skilling up kind of first point of clinical contact, whether that's the GP or physiotherapist to be better equipped in these kind of psychosocially informed elements. We've done some work looking at digital delivery of sort of pain management principles. In some ways that can widen access geographically, for example, if people are living in more rural areas. But of course, we don't want to create inequity through the digital divide. So we have to be conscious, particularly when we're talking about lots of enthusiasm for kind of digital delivery of pain management. We have to hold that in mind as well. And then I think when we think about some of the disparities in pain care and the inequities, we're really talking about addressing broader social structures that actually feed into people being marginalized in the first place. So certainly there's evidence that people that do particular jobs that might consist of, real heavy physical labor, that might be, from lower socioeconomic backgrounds, they may actually be at more risk of injuries or conditions that are painful. So we need to be thinking about, even in the workplace, things like preventative strategies for reducing those injuries. And when a person does have injuries, really supporting with, policy structures around things like flexible working. How do we enable people to remain in work if they're wanting to do that and able to do that? So I think there's a lot of different angles, both from kind of a policy perspective, as well as how we broaden out what has traditionally been quite a kind of localized focus of pain care broader into the community.
Yeah, absolutely.
Hope that answers the question.
Yeah, hopefully it does. And thank you, Shamil, for your question, and thank you for answering, Dr. Scott. Yeah, it's fantastic to kind of look at it from that, broad perspective, because when we do think of pain, we do think of like just localized management of everything. So it is quite important to have that into consideration with everything. And so an extension of social inequities is stigmatized pain. How can the stigmatization of pain affect those experiencing pain, and how are they able to manage that?
Yeah, that's a really great question. And I might just back it up a little bit to even kind of explain what we kind of mean when we talk about pain stigma. So stigma kind of fundamentally describes when a person or group are devalued for some reason. And that's usually because of a particular characteristic that society kind of deems as, undesirable. And we can think about this in two ways when we talk about stigma. So there is what we might call enacted stigma. And that's really kind of when negative attitudes are expressed by other people towards a person or group, in this case, the person living with pain or people living with pain. And then we can also talk about what we might call internalized or self-stigma. And that's really when the person living with pain, let's say, comes to believe these negative attitudes that are expressed towards them. So it's kind of this twofold thing. And there's been a fair bit of research looking at what's driving stigma in the context of pain. And one of the things is really that many persistent pain conditions, although it's kind of, they're all biopsychosocial experiences, where we're at right now in science and clinical care, many of these conditions don't have a clear biomedical cause. And that in many ways goes back to what we know about the nature of pain. It's really complex. It's actually quite unlikely that a single clear cause will be identified. It's going to be a complexity of different things. But because of that, because we often have kind of cultural beliefs about how pain should work, so we do think that there should be a clear cause for pain. So that kind of plays with that expectation. So there's some evidence that pain that persists when there isn't this clear cause, that's when stigma arises. And that's why people begin to kind of experience stigma directed from other people. I'll finish up this kind of part of the response, and then I'll kind of talk a bit more about the impact in management. It's also important, kind of going back to what we were talking about social inequities. So this kind of stigmatized aspect of pain also kind of intersects or relates to other aspects of a person's kind of health and kind of social identity to kind of have a really complex picture. So pain doesn't exist in isolation. It often occurs in the context of other health conditions, as well as mental health conditions. So for example, a person living with pain might also have diabetes. They might also have depression. Some might have substance use problems. And each of these other problems also carries a high degree of stigma in our society. So these things kind of compound one another. And then as we've been talking about, there's also evidence that pain is common among people from socially marginalized groups. And that could be on the basis of their age, for example. It could be on the basis of gender and racial and ethnic marginalization. So all of these factors can fuel the stigma and discrimination that a person with pain experiences for a number of different reasons. And we've done some work over the last few years looking at the impact of this stigma and discrimination. So we did a review looking at all the different studies that have been done to date. And basically, it was a very consistent picture that people that experience higher levels of stigma also experience kind of worse quality of life, or worse kind of indicators of their quality of life. And that can include things like greater levels of disability when they have pain, or greater levels of depression symptoms. And we also did a study looking at specifically discrimination, and this was over a long period of time. And we found that people with pain reporting some experience of discrimination, whether that was related to their age or disability, over a 6-year period, that actually predicted greater levels of depression and loneliness. So again, thinking about that social impact, people potentially are more isolated when they have these experiences, because it's fundamentally about excluding people from society. So that's the impact. And I guess I'll just finish up by talking about how we might manage this. And I think, again, I like to think about this like onion of kind of society. At the center of that onion is the individual, and then we can think about different layers of the kind of social system. So as a psychologist, we can support individuals to, I guess, maybe buffer the impact of experiences of stigma with something like self-compassion, for example. So we really kind of validate and acknowledge that, stigma and discrimination are wrong. You shouldn't have to face this, but we want to protect you as much as possible so that it doesn't have, this added layer of suffering. So can you kind of notice thoughts and feelings that show up for you around these experiences of stigma? And can you treat yourself with kindness when the world isn't treating you kindly? But of course, that's difficult when the world continues to not treat people kindly. And that's why we then need to think about the broader kind of rings of that onion, thinking about what's happening in kind of interpersonal interactions, let's say between the person with pain and their family, their friends, clinicians. Can we make some of those interactions more compassionate, more validating? And then those kind of broader social structures like policies, what's happening with disability benefits policies? Are they contributing to discrimination and stigma? How are things like pain portrayed in the media? Can we make those more compassionate, more inclusive, and so on? So really, it's this kind of multi-level approach that we have to take.
Yeah, thank you for taking us through that. That's really important for us to understand. And I love the analogy of the peeling back the onion and kind of seeing how many layers there really is to pain management itself, and really trying to nurture those even to those broader systems, and having those discussions with a lot of different groups of people on kind of removing that stigma from pain management itself. So thank you for taking us through that. And so you've also done some incredible work on a new form of therapy called known as ACT, a form of CBT or cognitive behavioral therapy. Can you speak about what this form of therapy is within the context of CBT, and how this may benefit some individuals in managing pain?
Definitely. So this kind of term, cognitive behavioral therapy, or CBT for short, really is kind of an umbrella term that describes a range of kind of related therapies and kind of therapeutic techniques. And they're very related, as I say, and overlapping. Fundamentally, it's about looking at the kind of relationships between bodily sensations, thoughts and feelings related to those bodily sensations, and actions that we do in response. Kind of more traditional forms of CBT often look at a person's thoughts about pain, let's say, and whether they're helpful or unhelpful, and has a range of different strategies for maybe targeting or changing those thoughts directly. So if someone's really kind of fearful about the pain, or has beliefs that, there's significant damage in their body and that it's not safe to move, there would be different strategies to specifically change those thoughts to maybe more helpful thoughts that would then hopefully reduce a person's fear and enable them to do more activities that they care about. in many ways, ACT is related to that, but there's a kind of slight difference there. So we very much view all of these thoughts and feelings that show up around pain as really normal and really understandable. And because of how our mind works, it might not actually be possible to change those in an effective way. So we focus less on changing thoughts rather than on helping people to notice and step back from their thoughts and feelings when that might be useful, particularly so that they can do things that they care about in their day-to-day life. So to say this in another way, we kind of focus on kind of three behaviors that we call behavior that's kind of aware in the present moment. So that's really noticing our bodily sensations, thoughts, and feelings with curiosity and without judgment, moment by moment. It's an openness to these experiences, again, in the moment. So allowing space for bodily sensations connected with pain, thoughts, and feelings to be there in the moment because they're already there, when that might be helpful to do rather than trying to push these things away. And a real sense of kind of connection with what a person cares about in life or their kind of personally held values. And then using those values as a guide for what they do alongside pain, rather than kind of prioritizing thoughts and feelings about pain as the kind of guide for behavior. But all of this is really kind of dependent on a specific situation and context. So it's hard to kind of say blanket statements about when to use these things. So I guess fundamentally, ACT supports people to live kind of life to the fullest alongside pain. It's not about positive thinking or pretending that the pain isn't there. It's really honoring that pain is there. It's really challenging. It's acknowledging all of those things and then helping a person to flexibly adapt so that they can live the best quality of life alongside what is.
Yeah, no, that's really fantastic. And we have someone in the chat, Dr. Asha, who's asking, would love to hear more if there are any other tools that are available for older adults specifically related to CBT, possibly with pain management as well.
Yeah, so it's a great question. And I would say in many ways, a lot of these kind of basic principles will be relevant. It's then just thinking about how we adapt these for specific populations, such as older people living with pain. And certainly, I guess that's another inequity in the sense that a lot of the evidence base will be done with, more middle-aged people. In the clinical service where I work, we follow this kind of ACT-based treatment. And less than 10% of our kind of population is kind of an older population. But that said, I think these basic principles apply. So some of these things, again, with a little bit of tailoring. So thinking about kind of focusing on experiences in the present moment, that might be kind of noticing in a non-judgmental way what's happening in one's body. Often the tendency with pain very naturally is to either try and avoid bringing attention to the body or to really hyper focus on the body. And this is really a kind of gentler way of saying, I can choose to tune into different parts of my body and notice what's happening moment by moment. And I can also make my attention flexible. So I can tune into what's happening in the world around me. I can tune into my thoughts. So that applies across age groups, I would say. I think the focus within ACT on what we call values or what a person kind of truly cares about in life, to a degree that might be dependent on a person's stage in life, and that might change over the course of one's life, particularly where there are role transitions or where there are different health considerations and different kind of social kind of contexts. But I think fundamentally the question we're often asking people with respect to pain is, so alongside this pain, something like, what do you care about in life? What's important to you? Even what do you want to stand for in life? And how can we use your answers to that to make some choices about what you do day to day alongside the challenge of pain? So it may be, people often do talk about kind of social connection in some shape or form as being something that drives them to have a sense of a purposeful, satisfying life. And the nice thing about this kind of word values is that let's say that one direction of social connection, that can look myriad different ways. And that might look quite different for someone who's older than someone who's, just starting university. But if that is the anchor and that's the direction, there's lots of flexibility that, someone can support an older person living with pain to explore what that might mean for them at that stage in their life.
Yeah, thank you for that question, Dr. Asha, and thank you for answering that, Dr. Scott, regarding that. I also wanted to kind of, you spoke a little bit about this kind of diversion, but we have a question here from Brendan Sherlock. If you wanted to unmute yourself and pose your question.
Yeah, I find that if you keep doing the same thing and you expect pain to go away, it's not going to do it. So some sort of diversion, it doesn't, I know everyone will tell you how to get rid of your pain, but no one can tell you your pain. But you've got to do something different if you want that. It may not go away, but it may not be as bad. Thank you.
That's a wonderful question. I love that almost phrase or slogan, do something different. I think, again, just by natural habits of how humans respond to pain, almost as a reflex, which is kind of based how we're wired, where we experience pain and then we want to do something to get rid of it. And that's the most natural thing. And that can work, and that might include distraction. So kind of taking our mind off the pain. The evidence suggests that when we kind of are really focused on distracting from the pain, so, just don't think about it, just don't think about it, that might work when pain is short-term or acute pain. The evidence when pain lasts a long time is that might not work, and in some cases it might not be helpful. And I like this, that maybe the difference between distraction and diversion. So we can, have pain, we can notice that and say it's here. We can also say there's other things in life going on. There's other experiences I can tune into, whether that's in my body, whether it's the sights and sounds around me, whether it's the things I'm doing in my day-to-day life that I care about. And it may be that, when a person is deeply connected with valued activities in life or things they care about, pain is along for that journey, but it's kind of a less prominent kind of factor on their screen, let's say. So whereas if someone is, avoiding a lot of life activities because of pain, we kind of say almost is like the only thing they can see, quite understandably. Whereas a more kind of diversion or kind of values-based activity approach alongside pain, the pain is still here, but maybe I'm kind of focusing on some other things that are also happening in the world around me, in my life around me. At times the pain will still capture my attention and I can notice that. And at times I can say, you're over to the side here. So it's a slight difference in kind of how we use the words, but I think it actually can have quite a massive impact on how people actually navigate life with pain, because I think at times people can get very caught up with, I should just distract myself, I shouldn't think about it, and then get very understandably stressed when they do think about it, because of course you're going to think about it.
Yeah,
Does that
absolutely.
help?
Thank you for your question, Brendan, and thank you, Dr. Scott, for that response. And even we have here in the chat, Sally George mentions the three words, well, three phrases, I guess, refocusing, deep breathing, and yoga. Just would love to hear your thoughts on that in terms of pain management as well.
Yeah, I think a lot of that really links into what I was saying. Again, a lot of these things are in the purpose of how you use them. So it's hard to say that any one strategy is useful or not. And again, it's always a very individual thing. Some people will find them useful, some won't. From kind of the approach that I use, the ACT approach, we see helpful purposes as being those that allow people to live life more consistent with how they want it to be. And that kind of refocusing, as I said, that might be a refocusing on different experiences, acknowledging pain is there, also refocusing on things a person cares about alongside pain. That deep breathing might be that real capacity to kind of just focus on something in the present moment. And certainly there's different types of yoga. But yeah, that there's a real kind of quality of that kind of mindful movement within yoga that connects with that kind of present moment awareness and openness that we look at within ACT. And there's lots of evidence that gentle movements are really helpful for people living with pain. Of course, it's a really challenging one because for many people, pain is a barrier to movement. And there's lots that can show up when they begin moving. And that's why kind of support to kind of manage that can be really, really important. And I think, so I work a lot with physiotherapists and, they're wonderful in kind of how they approach pain. They would often say, it's not so, at least the physios that I work with, it's not so much the specific exercise that matters. So they're not prescriptive saying you should do this or this. It's really about tuning into your body, bringing that sense of kind of gentleness and compassion, and finding something that, you are okay doing that might be, helpful or meaningful for you. So I think, yeah, taking a less prescriptive approach and one that simply it's more flexible and going to allow you to engage in that movement can be really important.
Yeah, that's fantastic, and I love that you kind of are approaching pain management with that integrated system of like
Mhm.
network of other healthcare professionals like physiotherapists.
Mhm.
And a really timely question from Tina Agrell. Tina, would you like to unmute and pose your question? You're here. Uh, no, if not, I can also ask it for you. She asks, can these tools or approaches be promulgated through training family doctors, physiotherapists, and pharmacists to use them as well?
Yeah, I mean, I think it's a great question. And I think that's kind of where healthcare systems need to move. So there simply are not enough psychologists, point blank. There's certainly not enough kind of psychologists specialized in pain. So I do think we have to think, about innovating with how we kind of disseminate some of these psychological principles across different healthcare providers. Again, as I said, it's not all just about psychology. We need to be thinking about kind of biopsychosocial management approaches, and certainly these other professionals will bring a wealth of experience and knowledge to those other elements as well. But yeah, certainly I think there needs to be a push in kind of getting some of these pain psychology, strategies and knowledge out there. And certainly I think at least in the UK and to a degree in North America and elsewhere, there has been a focus on specifically psychologically informed physiotherapy training. And there's lots of people that have kind of led that work. So that's been quite promising. I think the devil's always in kind of the implementation details and how we kind of scale this up at a population levels and really make sustainable healthcare systems that can enable this in the long term.
Yeah, absolutely. And thank you thank you for your question, Tina, and thank you,
Yeah,
Dr.
thank
Scott, for
you.
that answer. And yeah, if anyone has any other questions or comments, please keep them coming in the chat. And in that meantime, I'm gonna pose another question from my end over here. So I know we kind of briefly touched on this already, but what are some of the ways that we can really target systems to improve care for those experiencing pain in order for them to be a lot more person-centered and tailored towards their life experiences and culture, for example?
Yeah, so again, I think we can think about that kind of onion approach. I might think about just even, so again, I'm going to kind of come back to what I know about the UK context. I suspect, I did my training in Canada. I haven't been working there in a long time, but I suspect it's roughly similar. If we think about the healthcare system, the way it's been kind of developed and implemented in many places over the last few decades is really what we call kind of siloed care. So there's often been a real division of physical and mental health, for example, and a real division of specialties. So I talked before about, pain management being a very specialized, approach to care. It's often in, big cities connected with academic centers, and it tends to be disconnected in some ways from other aspects of care. So one thing that I'm really passionate about particularly is one, creating this kind of mind-body link and having services that represent that mind-body link. And certainly there's, a proportion of people living with pain that have really severe and enduring comorbid mental health problems. So this could be things like severe depression, anxiety, psychosis. We also know that unfortunately, many people with persistent pain also have really difficult life experiences, traumatic experiences, and there's lots of points within the healthcare system of exclusion. So some people who have really complex mental health needs, they might not be well served by persistent pain services because there's often this kind of chicken and an egg thing. Oh, maybe you need support with your mental health first, and then we can support with the pain. And that's always kind of a heart sink moment for me when I see that, and I always localize the responsibility for that in the service, not in the individual. So it's a problem of our service that we are not meeting your needs. So that's something, at least within the UK and hopefully further afield, if we can better, support that really truly integrated care of pain and, let's say, mental health management, I think that would represent a huge push forward at a systems level so that people aren't going through systems that aren't meeting their needs. They aren't excluded by design of services that don't meet their needs. And then they have that kind of internalized stigma and discrimination that it's saying something about them when actually the system's just not set up to support some of these people as it should be. So I think that would be, you know, a key move forward at a kind of systems level.
Yeah, absolutely. And I just had a follow-up question to that I just thought about right now. Um, do you have any ways of kind of getting more healthcare professionals involved in this kind of like multidisciplinary care? So we have more specialized like yourself who deal with kind of like the intersection of, for example, psychology and pain or like physiotherapy and pain, things like that.
Yeah, yeah, it's a great question. I think again, it kind of goes back to how we trickle this down in the education of various, healthcare clinicians. I know again, at least in the UK, in medical education, pain is actually a very small topic on the agenda. Obviously, there's so much to cover, particularly for kind of family practitioners or GPs. But if we know that pain is one of the most common reasons that people consult a GP, we know it's complex. We know it's not just about providing medications, although for some people they can be helpful. So I think it really kind of traces back to how we implement this within sort of education across a range of healthcare conditions. I think another aspect, again, thinking about kind of sustainability, it's not just a one-time kind of module that you learn about pain and then you're an expert in pain. I think there's a lot of reflective practice and supervision and support that's needed because as clinicians, so fundamentally, and I see there's a comment about, can yoga, for example, really help pain? And I think some of the tools that I'm talking about they're certainly not a cure for pain. And for many people, they won't even directly reduce the pain they experience. It's more about making life bigger around the pain or reducing that kind of physical and emotional suffering that comes with pain. So I think that's a really kind of important distinction to make. But that's also really important as healthcare providers because most of us, I hope, if not all of us, enter the profession with a desire to help relieve suffering. And, when you are day in and day out faced with people living with really horrible pain conditions that, you're saying, well, I can't actually help you maybe directly reduce that pain, but I can help you with the suffering. There's lots of hope in that second piece of it, but there's also a lot of emotional burden that comes with facing something that you might not be able to directly target day in and day out. And I think, again, part of a sustainable system is supporting clinicians with that so that, we don't burn out, so that we continue to have that empathy and compassion and that we can continue to take this kind of biopsychosocial complex lens. And that's not just a couple of lectures in whatever education program a person has.
Yeah, thank you for answering that. That's a really interesting way of looking at it, and yeah, I think it's really important for them to kind of really be involved with that work instead of just like, okay, yeah, I took 2 courses on this and now I know things, but it really kind of implementing it into like the way that they work is important. Um, we have a question here from Ramy Wood. If you wanted to unmute and kind of add to your question or pose it, if you're here with us.
Yeah, I sure am.
Perfect.
Well, it's kind of an interesting situation. From my own circumstance and work, interdisciplinary has been a scaffolding for me to now spend the last 30 years kind of working in this field. So it's kind of an interesting act of reflexivity professionally, but also personally, to be hearing the work being shared, but also knowing through my own work and research, but also my experience in my own life, just how impactful and accessible so much of this is. So I'm not sure exactly how to frame the best question, except more to say really that it's one of encouragement and exploration, that the reflexivity of how our communities and how professionals at whatever stage of their career, how we're all kind of coming to this aspect of our own professional work, and then in the convergence of interdisciplinary and transdisciplinary and citizen science and community, I'm overwhelmed, frankly, to hear the work and to have stumbled across the webinar this morning and to be as sincere in my encouragement at the horizons that we have available to us in the practice of this work moving forward. So it's more of a statement there. I apologize, I took a little bit of a platform, but I am so thankful and I'm so encouraged to see the group today and to hear this work. Thank you.
Thank you for that, Rami. I have to say I'm deeply touched by that. I think you communicated a lot of what I feel about that very, very well. So thank you for taking that platform and sharing your thoughts. And I agree. I think this is the way forward, and it's about how we resource this and how we kind of continue to make this system sustainable, so we can kind of continue this interdisciplinary work.
Yeah, thank you. Thank you for sharing that with us, Remy. Yep. And I think you added a link here as well if anyone wanted to take a look at that. That's fantastic. And yeah, we have Dr. Asha who mentions elders may adopt to reflexology along with yoga and CBT. So a lot of alternative methods to pain management. And I don't know if you wanted to talk about any of like alternative medicinal treatments as well. I know they might not be in your wheelhouse of work, but something like reflexology or even the use of marijuana and maybe how that's kind of related to like the stigma of
Yeah.
pain
Yeah.
management.
So a lot of really good questions, and I think particularly there's also again policy issues. So obviously in
Yeah.
Canada that's different than in the UK. I think for me it always comes down to pain management is incredibly individual, and we have to treat it as such. So I'm always very cautious of very sweeping statements about one thing being the thing. Again, always coming back to a very individual level. And then from my perspective and how I support people, we're always weighing up the costs and benefits. So if something for pain, helps you to reduce that pain and it has limited side effects or limited costs for your life, wonderful. That feels like it's a very helpful, workable strategy. In other instances, someone may say something does work for the pain, but actually it has all these side effects, or it means that my life is limited in these ways, and that's actually the thing that bothers me. Then we might say, well, how much is this actually helping your quality of life? So this kind of weighing up these pros and cons. It seems like a very obvious or simple thing, but sometimes people get in habits, particularly I think with medications that obviously when you go to a medical provider, there's that power differential. Many people say, well, I'm taking this because it was prescribed. I was told to do this, but framing that as a choice as well and saying, actually, if you don't want to be taking this, you don't have to if it's not working. So really just spending some time reflecting on what people are using and then allowing the individual to come up with their own decision and their own kind of conclusion about what is and isn't working for them. So that's never for me to say what's working. It's always for the person to say.
Yeah, absolutely. Thank you for sharing that. Just a
Thank
kind of a
you.
thought that popped in right over there. And Johanna, would you like to pose your question?
Yes, thank you. I'm just curious about whether or not there's a role for peer support at the community level to pain management. I always feel like the peer support part gets missed out in terms of the professionalization of various aspects of medical care. So I'm just wondering about that.
Yeah, no, that's an absolutely wonderful question. And I have a few different threads to that thought, but thank you for posing it. So I guess coming to the kind of approach that we do in my service, and again, it's a very unique context, and we're very fortunate in many ways to have this resourced. But a lot of pain management programs that have some sort of psychology element, similar to what I've been talking about, they're delivered in a group. So a group of maybe 10 or 11 other people living with persistent pain. And the striking thing clinically, and this is very anecdotal, but clinically, when you walk away from a pain management group, you've done all these nice clinical techniques and you assume that that's the function, and some of that may be true. Most people walk away with a sense of another person has seen me and has gotten it because they have a similar experience, and it's that social connection and connection with the group that's really, really powerful, and people kind of continue that beyond the group. Outside of that specific treatment context, I think certainly there could be a very powerful role of peer support. And if we also think about, resources and needing to scale up pain management principles, that seems like a quite useful avenue to go. In terms of the evidence specifically in pain, I don't know where we are yet, and I think that needs to be evidenced. I know one of our scientific advisors on that pain storm project that was briefly mentioned in my bio. She's a person living with pain, and she's connected with some researchers in Australia. And I think it may also be led by people with lived experience of pain. And there's a real interest in kind of peer support as an approach with that. So I think that's evidence and research that we'll see in the coming years. Stepping outside of the pain field, so I've done some work at the kind of intersection of pain in people living with HIV. But I've been, just had wonderful opportunities to connect with and learn from people living with HIV and in that community. And peer support has been absolutely fundamental to the progress and kind of well-being within that community. And I think particularly if you think about how stigmatized HIV has been over the years. So I think there's a real value in peer support and creating those connections that can buffer against stigma. And there's been wonderful activism in the HIV community. And I think that peer support has really enabled that. So a bit of a long and waffly answer to say, I think that there's real potential. I think some of the evidence needs to come, but I think there's lots that could be really, really useful about peer support if done effectively.
Yeah, thank you so much, Johanna, for your question, and thank you, Dr. Scott, for that response. We also have a question here from Salsabila, and she asks, how do we measure progress towards equitable pain care?
So these questions are amazing. I mean, I think there's lots of different ways. I think historically, and this kind of continues to be the case, it's been researchers that have defined that. More in terms of pain outcomes. I think part of pain equity and equity in this field is raising the voices of people living with pain to help us define what equitable pain care looks like. So, having that seat at the table to make those decisions is a huge step forward. With that said, I think there's a range of different approaches. So we can look at things like who's accessing our evidence-based pain treatments. Right now, that's currently at, specialty pain services in large part. An inequity within my own pain service is that we know that less than 10%, are older adults, even though we know that older adults have a high burden of pain. So we can look at, what sociodemographic background characteristics reflect the people that are getting these treatments. And then we can also look at, among diverse groups of people, how are people responding to different treatments for pain? And that can give us a bit of a barometer to say, okay, well, certain groups aren't getting access or they're not benefiting from as much. How do we tailor, how do we, one, understand the needs of those groups? What are the barriers? What are the challenges? And then how can we work with those groups to better address those needs?
Yeah, thank you so much for that question, Salsabila, and thank you, Dr. Scott, for that. I have one last question to ask you, and if anyone does have any other questions, comments, please, post them in the chat as we kind of wrap up the session. But if possible, would you mind touching on some of the challenges that might come with specifically addressing some of the pain management for the aging population itself specifically?
Yeah, no, it's a really good question. And kind of going back to what I said about even in my own service, older people are relatively less commonly seen. I think there's a number of challenges, including other comorbidities that the older population might experience, whether that's things like frailty, if there are cognitive challenges that may also be the focus of treatment. So those might be barriers to accessing pain treatment and then barriers to engaging potentially in current formats of treatment. So we would need to see how we can kind of mitigate those access and delivery barriers. Certainly there's also potential biases in clinicians and observers. So I guess at least in kind of Western cultures, there's a view that, pain is just a natural part of aging. That's not something that requires attention. And as someone that does something called acceptance and commitment therapy, where we're kind of acknowledging that pain is present and working alongside that, that doesn't mean that we don't provide support when pain is present or a natural part of life. And certainly there are management strategies, and there could even be reduction strategies if pain is appropriately identified and assessed in the older population. So I think it's kind of looking and working with clinicians at identifying some of those biases. And I think thinking at, other comorbidities at the more extreme end, when there are kind of cognitive impairments or things like Alzheimer's and dementia, there can be issues with communicating pain and detecting that pain. And kind of circling all the way back around to my undergraduate mentor, he actually did some really fantastic work and continues to do on the assessment of pain in people with Alzheimer's and dementia. So I think we need to think about relying on our tools for self-report may not be, the best fit for that population. And we need maybe other indicators like behavioral assessments or kind of reports from carers and much more involvement of the carers as well. So lots of different avenues, I think, to pursue.
Yeah, thank you so much for going through that with us. So now that we are quickly coming close to the end of today's Global Cafe, before we wrap up, I would love to hear your key takeaways from today's discussion. So I'll give you a little bit of time to gather some of your thoughts as I'll go through a little housekeeping for the Global Cafe. As you may all may not know, today will be the final Global Cafe session for this year, 2024. We all look forward to 2025, where we will return and start off the year on the 10th of January with Mr. Gregor Snedden, the new Secretary General of the IFA, on the topic of a discussion on the future of aging and of the IFA. Perfect. So now that we're kind of gone through a little bit of that, we're back to you, Dr. Scott. In a few sentences, what are some of your takeaways from our conversation today that you'd like for us to leave with?
I mean, I'm just really impressed. I've not been part of one of these global cafes before. Just, the thoughtfulness of the questions, the engagement, the encouragement for kind of taking this approach has been really wonderful for me to see. And it's really heartening to see so many people with vested interests in pain management, particularly in the older population. So I'm encouraged, I think. So I know the International Association for the Study of Pain, I think their current tagline or slogan is working together for pain relief. I've obviously presented my side as a psychologist. As I said, this work doesn't exist in isolation. It's not just about psychology. It's also not just about clinicians. So I think this kind of idea of creating platforms, creating communities where we can work together for pain relief, for improving quality of life in the presence of pain, that's really what it's all about. And that's what will move us all forward.
Absolutely. Thank you so much. And before we sign off, I would also like to thank everyone for another great week of our Global Cafe sessions. Special thanks to Dr. Whitney Scott for joining us today, Haleon for their partnership on this pain management series, and a great thanks to the incredible people working here at the IFA who have supported this and every Global Cafe, in particular Miss Luana Calnago. Also, as another ending note, as IFA is nearing 5 years on our Global Cafe series, we have launched a survey to get some feedback on how to make this experience more impactful and meaningful to you. So we would absolutely appreciate your time in completing this brief survey, which has been posted in the chat, I believe, by Luana. So even if you have more topics or things like pain management, but you want a different aspect of it, we'd love to hear from you and see what we can do coming into 2025. So thank you all on behalf of the IFA. We all wish you a very happy and safe holidays and hope you all have a wonderful new year. So we hope to see you all on the 10th of January in 2025 for our first Global Cafe of the year. Thank you so much.